I think it is of great benefit that women also receive testosterone replacement therapy. Do we see an increase in lean muscle mass with testosterone replacement therapy in females? Absolutely. Decrease in visceral adiposity or body fat? Absolutely. Do we see a improvement in quality of life? Yes, we do. What we find on average is that most of my young female patients into their elderly age, of course, are suboptimal when it comes to their testosterone levels. And therefore, I think it is of great benefit that women also receive testosterone replacement therapy. Is it safe? Is it effective? All the stuff that we could talk about there. It's extremely safe and extremely effective if done appropriately. Okay, so one of the means in which we should be using testosterone for females is, of course, safe and cautiously. We don't want to give women so much testosterone that they end up with virilizing effects, which would be male-like, androgenic-like qualities. Hair growth on the chin or the chest, God forbid, right? Clitoral enlargement, voice deepening, all these things that, of course, are certainly they're scary, and I'm glad that I hope that you think that, because that means that you're probably a pretty good provider and you're thinking about your patients and wanting to make sure you get the best results for them. But the problem is that if you just stay within that zone of fear and discomfort, well, your female patients aren't going to get better, and you're probably not going to have a whole lot of success with them, even if you do see them, because you're too afraid to give them enough testosterone so that they do feel better. Here's a great example. So one of the things in terms of testosterone replacement therapy in females, I would say, especially over the last, let's say 10, maybe 20 years, there was one thing that really kicked off, which was hormone replacement therapy pellets, specifically testosterone pellets. Sometimes those testosterone pellets are combined with estrogen for women. And what I found to be true is that, and I'm not a big fan of pellets, and I can explain why in a second, but what I found to be true is that many of the women really enjoyed the way those pellets felt, in the sense of the fact that they resolved their symptoms. They felt their mood shift from, depressed and down and lethargic to happy and confident and full of life and vigor. And it's because those pellets would release copious amounts of testosterone over the course of their lifetime, the pellet lifetime, depending on the female, 3 to 4 to 6 months max. And as pellet providers started recognizing appropriately that their female patients all seemed to get better when they got testosterone, but if they looked at a peak level of that pellet testosterone, their mouths and jaws would just drop open, because we would see numbers in the hundreds, right? I'm talking like high hundreds. It could be 4, 5, 6, 700 at times of that pellet's lifespan, which would drive their female patients' free testosterones probably into the 6, 7, 8 range. Now, again, according to the conventional reference range, a female in menopause, for example, should have a total testosterone no greater than 60, 75. Their free testosterone could range anywhere from 0 to 3 or 0 to 1. Seriously, I can't even make this stuff up. So what I want to clarify is that in conventional medicine, a free testosterone of 0, if you are in menopause, is completely normal. And I will give the devil its due here, because that is accurate to some degree. Women are going to produce very little, if not any, testosterone, menopause and beyond. In fact, really beyond the age of 25, 30, most women are going to produce more free testosterone than 1 nanogram per deciliter is what I'm referring to, by the way, here. Most of them are going to be in the zeros, 0.1, 0.2. That's just reality. Now, again, I think there's a lot of issues when it comes to environmental stuff there, and we've talked about that many times on this podcast. And of course, diet and exercise and lifestyle. But I think we're behind the 8 ball because especially of the endocrine disrupting chemicals, leaving us in these really poor positions. That said, again, once a female enters into menopause, it's a zero-sum game anyways. They are not going to win. They can't, out supplement or out diet or out exercise this fact of human biology, which is that women, literally their ovaries shut down and many other things with it, and they're left feeling like crap. So again, when we're using pellets, all of a sudden what we started seeing is these massive spikes. And if we looked at some of the studies, which was looking at, this average range of 150 to 350 nanograms per deciliter total testosterone, what they were finding was that women in that range tended to express a increased quality of life. They felt better there. And again, it's like 30x higher or more than what was seen in the conventional reference ranges. I just shared an email about DHEA and the same results, right? We gave women, researchers gave women DHEA, and again, another male-like hormone, an androgenic hormone, 50 milligrams of DHEA, which is a big dose. But these are elderly women. They can tolerate that usually. And we're seeing DHEA levels in the thousands. And again, the reference interval ends at like 150 if you're an old female. And yet when we hit 1,000, 1,300, we saw an increased quality of life, decrease in body fat, improvement in insulin sensitivity, and a decrease in insulin resistance. So now all of a sudden, again, these labs and these reference ranges don't hold a lot of water. Even the ones that I've surmised just from my own observations and whatnot, I don't let them hold a lot of water, because again, I'm just guessing at the end of the day. It's my best educated guess. This is where I happen to find a lot of symptom resolution for some of my patients, but it's not to say that some patients don't need more or don't need less, because a serum value at the end of the day is not that helpful. It really, really ultimately is going to depend on that specific individual and how they tolerate that hormone and how they metabolize it and how they utilize it. Okay. I'll get off that stump speech. Going back to pellets here for a moment. So again, I think to, again, give the devil its due, because I'm not a big pellet guy, because I think there are much better ways to do hormone replacement therapy. But I think what pellets showed us is that, hey, women can tolerate way more testosterone than you think, especially women menopause and beyond. We know that to be true. Women earlier in their younger years, they do not tend to tolerate as significant amounts of testosterone and DHA and things of that nature. They'll end up with oily skin and acne and all that sorts of stuff. Again, excluding women with PCOS who, again, we're kind of, that's apples to oranges here. But again, what I emphasize to my own students in my course is that we can achieve these results with topical creams and injections flawlessly. The thing you have to let go of is that there's this, danger when it comes to testosterone replacement therapy in females. It is not dangerous. It is not ill-advised in any way, shape, or form. And the sooner we can kind of let go of that notion that this stuff is the devil incarnate and it's actually a bounty to human life and dignity, the more we can serve our patients. So in terms of creams and injections, typically, in terms of the creams, concentrate the cream higher and dose it as appropriately as possible, once or twice daily. Injections, similarly. You might need to just dose that higher than you think. And I'm not going to give dosing guides here because, again, it's kind of crossing a boundary in terms of legalities, but I explore all of that in great detail in the master course. And I'll explore a lot of these things even further in the advanced female course coming out later this year, which is going to be epic. But what I, again, have found is that once providers and students really feel more comfortable and confident with testosterone replacement therapy as a whole for females, they can start utilizing testosterone creams and injections and things of that nature and get very, very, very good results with those without the, risk that, again, pellets could provide, which is way too much testosterone, God forbid. Again, it's not super common, but if it happens, you're stuck with that pellet for months on end versus, again, creams or injections. If we get levels that are just way too high and when women are symptomatic of, God forbid, viralizing effects, we can lower that dose very quickly and appropriately. We're also getting away from potential infection risks. And frankly, if we have a female in her 30s and she's going to do pellets until she's 80 or 90, because she should do them for the rest of her life if she wants a great quality of life, that's a lot of freaking procedures. In medicine, we always should opt for the method or the therapy or the procedure which provides least invasive, most effective results. And again, that's where I think creams and injections are fantastic. And it also puts some of the emphasis back on the patient in terms of providing their own care. I love that autonomy. I think it's really important. I don't think it's like this big psychological game. I think it's real. I think patients should feel like they're a part of their care and that they're doing this for themselves. And it's not just always an easy button every second of the day. And I have to feel like crap until I go see my provider to get my pellet. I think that's important. And by the way, I'm not disparaging any of you who do pellets. I really am not. I don't think that's necessary. I think my quote has always been, any amount of hormone is better than no hormone. Okay. Unless you're doing non-identical hormones. I'm not a huge fan, but I think it's really important that men and women get hormone replacement therapy in some way, shape, or form. I'm just a big advocate for ensuring that it is the least invasive and most effective means possible. I think that's true of medicine in many ways. So when it comes to women and testosterone, what benefits do they get? Well, this is again where we don't have to rewrite the script here. We can see the benefits in women because we know the benefits in men. And again, I understand this is not an exact one-to-one, but if you zoom way out, it kind of is in a lot of ways. Do we see an increase in lean muscle mass with testosterone replacement therapy in females? Absolutely. Do we see a decrease in visceral adiposity or body fat? Absolutely. The fat between the organs? Totally. Do we see an increased bone density? Absolutely. Do we see an improvement in cognitive performance? Yes, we do. Do we see a improvement in quality of life, which again is always that vague subjective thing that we see in studies and we've heard about since the beginning of time in nursing school and med school and stuff. And what does that mean? Well, we all know what it means because it's like love, when you're in it. That's quality of life, an increased quality of life. That's what we see in every single study with testosterone replacement therapy. When they're asked, how are you feeling? How's your quality of life? It's an improvement globally. Will we see an improvement in lipids? Absolutely. What about A1C? Yes. Fasting glucose? Totally. Fasting insulin? Yep. Anything we've seen in the male studies, we have more or less seen in the female studies as well. And if we haven't seen them in the female studies, I think it is fair to say, based on the fact that we are human beings and we have some understanding of, the fact that we're men and women, yes, but the fact that we have very similar structures in many ways. Do we see the benefits that we see in testosterone in men as we do in women? Yes, we do, of course. Now, do we want to limit those viralizing effects and things like hirsutism and stuff, hair growth? Well, of course we do. Yeah, and that's not hard, guys. It's really not hard. You practically have to go out of your way to cause that to happen in your female patients, or they have to go out of their way to do it. Right? I always tell my female patients, as long as you don't abuse this and dose it 2 or 3 times higher than what I've recommended, this is not going to be an issue. It's never been an issue. In fact, I would lose my job. I would not have a successful business if every single woman I treated was walking away with a beard and a voice that was lower than mine. Do you see what I'm getting at here, guys? Testosterone replacement therapy is a great and bountiful thing to provide to your female patients, and avoiding it creates a great health disparity for them. Because if it improves all those things, well, not having it will then kind of not improve any of those things and make those things worse. Women with low testosterone are at greater risk of fractures and bone disease, osteopenia, things of that nature. Now, of course, estradiol and progesterone are very, very key there, of course, but so is testosterone. If testosterone also converts a little bit to Estradiol does not help a little bit? Of course. What about testosterone maintaining muscle mass and therefore indirectly helping support the bone structure by allowing the female to walk and do some resistance training and things of that nature? Does that not help maintain healthy bone structure? Of course it does. Yeah. What about the fact that testosterone helps prevent things like depression, that feeling of lack of motivation and drive? What if it helps women feel more active and robust? What if it helps women have a better sex life, just like men? Because that goes away when women hit menopause. I hate to say it, but it's true. And any woman in menopause would tell you, well, probably way before menopause, but especially menopause and beyond, does that ruin marriages? Yeah, big time. Big time. One of the most profound things that I've felt in my clinic after all these years of doing hormone replacement therapy for men and women, but especially for women, is that very fact that their libido drops so significantly that they no longer are interested in having sex. And it's such a, unfortunately, still weird and taboo subject, at least I feel like conventionally speaking, not in my office and hopefully not in yours, but I think it's insane how sex is not considered and or downplayed in conventional medicine and just in our modern society at large. And I'm talking about sex not in the sex industry pornographic version. I'm not condemning or condoning that necessarily. Well, I am condemning that for sure. I don't think that's a great idea. But what I am getting at is that when we're talking about sex, I'm talking about it as one of the most foundational pieces of human biology, human emotion, and even spirituality in a lot of ways. I think it's that important. And when I find that my female patients have lost that interest and desire, and not because it's their fault, it's just because that they, their ovaries are gone and they don't produce any hormones anymore and their testosterone's garbage and they feel awful. And it's kind of the last thing that they want to do. Unfortunately, their male partners typically don't exactly feel the same way. Now, even a male with low libido typically is going to have better libido than his wife at 40, 50, 60 plus, because she's going to have zero testosterone left and zero hormone left. The impact that has on a relationship is mind-blowing. And again, I don't think it's discussed often enough in clinics. I think a lot of these patients, if they especially want to hold that to themselves, or they just, assume that's just a natural part of aging, because of course that's what most of their primary care providers are going to tell them. And even some of their OB-GYNs, well, Betty, you're 55 years old. That's just part of aging. You're going to get tired and all that stuff. And I'm sorry. All right. And you sound depressed, maybe take an antidepressant, which by the way is just going to lower your libido more. This is what I hear from my patients. And when I talk about it with them and kind of open that door to communicate about it, it's amazing how much you can learn from them about how much their relationship suffers. And they don't want it to suffer, but they don't know how to make it better. And it's not their fault, again. But providing something as simple as testosterone replacement therapy, and I think you should be providing all the hormones, by the way, not just testosterone, but just testosterone itself can have such a profound impact on these patients' relationships. Thank you so much for checking out this clip and tuning in. I hope you enjoyed it. If you really liked it, I definitely recommend that you click here to watch the whole entire video where I go into much more detail. Thank you again for joining, and I'll see you there.